Just wanted to introduce the respiratory therapy session by going over some of the newer things. If you have been a part of our discussions before, I'll try not to repeat too much, but in the essence of having new learners in the audience as well, wanted to share with you. So I am from Chicago. It's very cold there right now, although we are having unseasonably warm temperatures today, so a little bittersweet about that being here, but nice picture from our clinic room here of our lakefront. So I'm going to describe what are some of the challenges that we as ALS healthcare professionals face with respiratory issues, and several of them are evolving as we speak with devices and how insurance companies cover them, and I'm not going to go into those in great detail. My email address will be at the end of the presentation, so feel free to email if any questions come up. I wanted to also discuss sort of the timing of interventions, when to start which device. That seems to be a common question a lot. And also discuss people who are in their homes with the non-invasive or mechanical ventilation. So most every clinic in the world is checking spirometry, which is a forced vital capacity. It's kind of become our gold standard. One of the missing components often is to do it also in a supine or lying down position to help simulate the sleeping, breathing capacity. And so be sure that you're using devices that can also accommodate people who have bulbar features of the disease. There are adapters to the equipment out there that help to put a mask on the device if people can't form a seal with a mouthpiece. Lung function testing is something that should be done at every visit on every patient. This is something that is an indicator. Not sure what that was. This is something that is an indicator of where your discussions should lie. Should we be talking about using non-invasive ventilation? Should we be talking about hospice? Those neurologists should know the forced vital capacity numbers before they go in the room with their patients so that they can guide their conversation for the visit. One very easy, simple test to do at home is check with your local respiratory DME companies to do overnight oximetry. This is often abnormal even with a normal vital capacity, and so you can catch early hypoventilation during REM sleep and start non-invasive ventilation earlier with looking at the simple test that the patient can do at home. So one of the first things that we can do when patients come into the clinic, they say, what can we do? And in a lot of places, they don't do anything until the patients start having breathing symptoms or until their FVCs are less than 50%. And one of the things that you can do is to get them breathing better when they are sitting position, because they are going to be less mobile than they used to be. So you want to make sure that their posture is appropriate, and this is where your whole clinic team needs to be involved. Your occupational therapists and your physical therapists are very necessary in ensuring that patients are breathing well. We also have our orthotists to support us with abdominal binders, and the correct positioning for an abdominal binder is to be below the umbilicus to support those lower abdominal muscles to give them better breathing. Also, breath stacking exercises. By show of hands, how many of you are teaching these in your clinics? Very good. Next time, I want to see everybody's hands up. So, this is a very simple exercise. This first information from Dr. Lexon came out in 2006. It is a very beneficial thing that you can do at any point in the disease, and it helps to keep those range of motion exercises going for chest wall muscles. If you just teach it in that capacity, it's something that the patient can do. The International Ventilator Users Network put this article out in August of 2011. Can be found online, and it is how to order the pieces that will help you to get set up, and I can also share that information with you. There are also posters that have been presented at other meetings showing that it does help to improve the decline in FVC and give the patient the ability. And in this picture, you can see that the red circle on the right side graph is where the patient can breathe on their own, but the gray line is where they should be breathing. And so to use a passive range of motion exercise like with the ambu bag helps them to get that bigger breath. And that not only gives you airway clearance and prevents mucus from plugging, but it also does range of motion for the chest wall. So nebulizers and suction devices have been around for a long time, but something to keep in mind is that oral care is also very important in prevention of bacterial and lung infections. And something that a lot of places are unaware of are the attachments to the suction devices that you can use for suctioning for oral care. And this is also something the patient can be doing to prevent pneumonias and respiratory infections. You want to make sure that they're keeping their secretions thinned out. A lot of times you've heard the old saying about how everybody is dehydrated all of the time with all the caffeinated beverages that we have. Not a lot of people are as hydrated as they should be, and especially when they're less mobile and it's more difficult to get to the bathroom, it's harder to keep them well hydrated, which helps with their respiratory function as well. So again, another member of the multidisciplinary team that is important here is the dietitian, and keeping your patients well hydrated and well nourished to help improve their respiratory function. One of the devices that can also be started at any time without any kind of qualifier for measurement or any kind of requirement is a mechanical insufflation exsufflation device, also known as a cough device. These devices are now on the market. There used to just be one. Now we have 3. The older one obviously is still around, but there are newer ones. The one on the bottom right-hand side also now has a feature called PAP on pause, which is positive air pressure. So in a lot of patients who have especially upper airway weakness and bulbar dysfunction, this is from 2004, where Jose Sancho showed that mechanical insufflation exsufflation can collapse an upper airway when there's weak muscles. And so having that positive air pressure available helps them to transition from insufflation to exsufflation with less trauma to the upper airway. So that PAP on pause feature is something that's really nice for our patients, and they really love it. So I also, in my presentation, have included some of how you would order these devices, what settings, what medical documentation to include in the medical record, so that information is included on these slides, but I'm not going to go through what those exact wordings are, but just so some people have the example to use when you go back home. So high-frequency chest wall oscillation is another technology that can be started. Recommended that it's started once people become less mobile and their secretions are harder to move and clear. So one of the issues is that people wait until they get a pneumonia to start this device, and the issue is that we're trying to prevent pneumonias. So using these devices early in the disease can help prevent hospitalizations, which are very costly, and help keep people at home, keep people from going to the ER by having these devices at home. Again, I included some of the wording. Available in the inpatient setting now is something called a MedInNeb, which is a positive air pressure device that includes a nebulizer and does high frequency chest wall oscillation included. We're hoping to see this device come into the home setting soon, but it is available in the hospital. So if your patients are admitted to the hospital, they may have this device. And if they're using it in the hospital, then you need to make sure to send them home with a nebulizer and a vest. These devices also will soon have remote monitoring capabilities where you can go in online and change settings so you can look at how much they're using their devices and how effective their therapies are. And that's very important when patients are 2 or 3 hours away from the clinic and you're trying to do care from the clinic and make adjustments. Sometimes it's harder to send someone to the patient, and now online monitoring and online devices are making it easier for us. So how do we know if these therapies are effective? And again, the idea here is to prevent respiratory infections. And so the other things that you'll hear patients say is that they're not breathing as shallow, that they may have an improved swallowing function, which we'll hear some speakers this afternoon discuss. Constipation is also an issue in these patients with less mobility, dehydration, and ineffective breathing. So if they have improvement in their constipation, that's something that can be an effective measure in keeping them home and out of the hospital from getting respiratory infections. So these are sort of secondary side effects to making sure we're optimizing their respiratory care. So a little bit about non-invasive ventilation, which is a whole workshop in itself. But things that we have to think about is that in the inpatient setting, when a patient is on a ventilator, the job is to do what they call ventilator pneumonia prevention. And so we have to apply that in the home setting too. So you want to help patients understand what they need to be doing at home. They need to sleep with their head of the bed up. So they may or may not need a hospital bed. Maybe they just need a wedge cushion, something to help elevate their head. And that the earlier they start these therapies, the more adjusted to them they're going to be, and that they do better in the long run when they really need the device if they don't wait to start the device. So for those of you who are a little newer to the field, in 1999, this work came out that people who use the device 4 hours a day or more survive longer than people who use it less than 4 hours or don't use it at all. And so to get someone started, Medicare and a lot of the United States insurance goals are to at first have goals of 4 hours a day compliance measures for at least 70% of the time in the first 90 days. So a lot of times you have to encourage the patient to use the device, practice during the day, get started, get the different kinds of masks that are available, try everything out, desensitize during the day with it, and when they can watch a TV program and maybe fall asleep in the afternoon with their device, then they can go to bed with it. And this is not an easy task. It sometimes takes people 3 or 4 months to get used to it. And for insurance companies, all they're looking at is the timing, how long the patient's using the device. The insurance company could really care less about how effective it is, and that's really what we're looking at. So when we're looking at the way that we can help the patient to use the device, there's sort of a 3-letter thing that we came up with. Not only the compliance, but are they actually using it, but how well does their mask fit? Are they having any leak? And how well is it effective in getting them the right tidal volume? I've included this link so that you can, when you get home, you can see, well, what tidal volume should we be shooting for? You can look up by male or female how tall they are and how many cc's per kilogram of air they should have. We also now have the online monitoring for a lot of the respiratory devices. And so just to give you a little example, I can go in when a patient calls and says, I feel like I need more air from my machine. I didn't really sleep well last night. I can go in live time, look at last night, look and see how well their leak is, if they're having any apnea, hypopnea indexes show up, if the mask is fitting well, and how well the pressure is working. And I can change the settings online from my office and help the patient adjust. And the next day, check with him and say, how was it last night? So these technologies are happening. They're happening so quickly that it's very hard to keep up with. And so one of the charges that I have to the field is to designate one or two people in your clinics to work with the respiratory DME vendors and set these things up, because it will be improving the quality of life for your patients if they don't have to come into the clinic for a visit just because they feel like their machine needs adjusting or they need a new mask. And especially in Chicago, we have bad weather, and if it's hard for them to get out, they can't get out. And so having this remote monitoring is very nice. The last 2 points to drive home is about emergency backup planning and having battery backups, because no matter where in the world you live, power does go out sometimes, and power is hard to make portable, these devices. So the vendors are doing a better job at making the batteries on board, but not every where has that option. But just make sure that your patient has a plan for having backup power. And one other really nice resource is, again, from the International Ventilator Users Network, is a checklist for home, for whether they're on a mechanical ventilator or they're on a BiPAP, having a checklist that they can make sure that they have everything set up that they need for emergency situations. So I've included that there too. So thank you very much. Any questions?
We have a few questions. Thank you, Jennifer.
Mm-hmm.
Nancy Hoke, I'm a nurse at the Providence ALS Center in Portland. Can you tell me what your protocol is for choosing a vest versus a cough assist? Because insurance in our area will not pay for both.
So in most areas, that is an issue with insurance payers. So the issue is, what does the patient need? If they need both and you can provide the medical documentation, then work with the vendors and the companies to appeal those decisions as far as you can take them. And a lot of the vendors do have appeal departments that will help, and they also have patient financial assistance programs, or perhaps your local ALS groups that have grant programs or lending banks to get both therapies for your patients if they need it. Some people don't need it, some people do, and this is why also this is not necessarily a cookie cutter type of recipe for this disease. Every patient is individual and has different needs. Some were smokers, some were asthmatics, some have other respiratory contributing factors, and so it does kind of have to be customized. And if you feel like they need both devices, try to work out what you can. So.
Hi, I'm Amrita from India, and I wanted to ask you about use of nebulization for patients with ALS. Most of the times we see that patients who have bulbar dysfunction, they're not able to cough very well. So if we use nebulizers, sometimes the breathing difficulty increases because the secretions are mobilized, but they're not able to cough out.
Sure.
So would you be able to give any guidance as to when to stop using nebulization or what to do with nebulization so that that can be?
So sometimes it just depends on what is going on. Is it thick and goopy? Is it runny and drippy? You use the medication to customize to the issue. And some people have very runny saliva out the bottom of their mouth and very dry, thick secretions in the rear top of their mouth. So you could have two things going on and may just need to, again, kind of customize what is needed for that patient. Do we need Botox in the bottom to fill the salivary glands, and saline to loosen the secretions, and perhaps not use an actual medication, just something to moisten the thick secretions? Really kind of depends on your patient. All right, thank you.
All right, thank you, Jennifer.